Good afternoon, everybody. We're just going to get started on our breakout session for Let's Talk Delirium. Really delighted to have you all with us today. And for those of us online, if you're online this morning, we'll have been through this already, but for online participation and troubleshooting, I know everybody's got the camera off already and it just helps with the bandwidth. You can use your chat box both to take part in the discussions, but particularly in the Q&A. And Joan Marie and Jamie are manning the chat box so that we can bring your questions into the room as we go through our session. If you have any technical issues from the online perspective, then there's the WebEx chat box or the email address below, and we'll pick that up for you. So, I'm Megan Bateson. I'm the Senior Improvement Advisor at Healthcare Improvement Scotland for the Acute Care team, and I'm delighted to be here today in place of Dr. Lara Mitchell, who's our Clinical Lead for Acute Frailty, who unfortunately couldn't be with us today. Today we're going to hear from three speakers, and particularly at the beginning, Dr. Hazel Miller and Frances Aitken. So Dr. Miller's going to start us off with a chat through delirium, and then we're going to move on to Frances and her work with stress and distress in NHS Lothian. So our aims of today are to explore the signs, symptoms and treatment of delirium and its impact on the risk of falls. We're going to share learning about managing stress and distress in patients with delirium and dementia, and provide an opportunity for you to network with colleagues with an interest in falls improvement, and particularly delirium across health and social care. Is that pointer working for me, Drew? No? Is it? We're having a little technical drama. That's fine, don't worry. So I'm going to invite Dr. Miller up in a moment. So Dr. Miller has been a geriatrician in GRI for more than 10 years and is a quality and safety fellow. And she's passionate about delirium and dementia, and particularly in acute hospitals and person-centred care. And we're really delighted to have you with us today. So thank you so much for coming. Just see if we can move your slides on, and then we'll be fine. We good?
I'm never that good with the clicker, so I'm glad that you had the technical drama and not me. Thank you very much, Megan. Lovely to be here, everybody. I'm Hazel. I'm a clinician. This is a very clinical talk. It feels strange, actually, to be in work clothes without my sleeves rolled up. It's a little bit helpful. So it's very clinical, which hopefully is going to be helpful for you all today. And I'll see if I can work that. Yes. So I'm going to talk a bit about what delirium is, why it's important, and then about what good delirium care looks like. Now, what is delirium? It's something that happens to people. And this is our person who we're going to have illustrate the talk. This is Miss Lily Ego, slightly tenuous. Normally I would ask this question to a group, what is delirium? I think people here will know and they're interested, but people often say to me, oh, delirium is acute confusion. But when you come to actually look at the DSM criteria, of course, it's not the confusion, it's the change in attention and awareness. It's a really key feature in delirium. And that can be having too much attention and awareness when you're hypervigilant, when you're looking all over the room and distractible, the hyperactive delirium, or when you don't have enough, when you're sleepy, struggling to maintain that focus, struggling to shift focus or to pay attention to the thread, the hypoactive delirium. And then you can have mixed delirium when the two switch between the two. It develops over a short period of time, so it's something that's fairly acute as opposed to the more gradual progression of other cognitive issues. And you have fluctuations, so good days, good hours, bad hours. Coming on to the next thing, the additional disturbance. So this is where the confusion fits in. So this is when you have problems with your memory, you might not know where you are, possibly language problems, hallucinations, all these kind of things. That kind of fits under C here. For it to fully meet the DSM criteria, it says that you have to not have a coma. Now, I think I put a wee question mark next to this because in practice, we do see a lot of people coming in, particularly vulnerable people who might be GCS 8, profound hypoactive delirium, and I think that is delirium. So in the real world, not so sure about that one. And then when we're looking here also about the last point that you have to have a demonstrable cause of what's causing the delirium. And again, I think sometimes in our most vulnerable people, it's not clear exactly what that cause is. It could be something that's so subtle that we don't always manage to identify it. But what people do say is they say, that's not my mum. They don't recognise the person in front of them. And that's really, really typical when someone's got a delirium. And why is it important? Well, one of the first thing here is really about the experience, the immediate experience for the person. And delirium can be really, really horrible. The stress and the suffering of the person who has it, and also their loved ones who are witnessing this, especially if they're not quite clear what's going on, can be extreme. I think hopefully for those of you who are online, there's some patient experience videos coming up in the chat just now. Worth having a look because it really hits home to us why this is so important. And these experiences can stay with people for a long time. When we think about the person with a hyperactive delirium, it might be obvious that they're suffering. They can be paranoid, phoning the police, that kind of very distressed behaviour. People with hypoactive delirium can often have just the same levels of distress. They're just not manifesting it the same way. It's not as obvious to us. So, in healthcare, we're in the business of easing suffering. And this is why, one of the reasons why delirium care is so important. And then the other part of this is all the bad things that happen when someone has delirium. All the things that we don't want to happen to the people in our care are 2 to 3 times more likely to happen if they have a delirium. So falls are part of this, which is why I've been asked to speak to you all today. Infections, skin breakdown, dying. If you've got a delirium, you're 2 to 3 times more likely to die than the person who has the same severity of illness, the same underlying comorbidities. You're just much more likely to have all these terrible things happen to you. And when we're thinking about it from the point of view of the individual, but also of the health system, delirium is associated with longer length of stay, much higher rates of needing to go into nursing home care. There's a growing body of evidence in this about the risks of dementia after delirium. So we know that if you have delirium, you're maybe 8 times more likely to go on to develop dementia. If it's recurrent, 14 times more. So really high risks that can happen as a result of delirium. And there's things we can do to prevent some of it. We can't prevent all of it, but we can certainly do stuff to help reduce the risk of delirium. And that's why it's so important as well. There's something we can do here. I think the need for good delirium care is really pressing. It's on a personal, but also on a system level. To my knowledge, delirium risk reduction is the only thing that's ever been evaluated by NICE as giving a cost saving for quality gained. So you get better care for the person and you save money. And these things are going to even be more important with the changing demographics that we're seeing now. Oh, let me try this. I'm struggling again with the clicker. There we go. Right. So sign guidelines for delirium came out 2019, just different worlds before everything changed. They've been a really great step forward for delirium care in Scotland and outside of Scotland as well, have given us a really great set of standards, very practical, and has extended the scope outside the acute hospital of what we've been doing. These are the comorbidities that were reviewed for the guidelines and also give you a good impression of the kind of people who are more likely to get delirium. Because most people, if they have a big enough insult, will get delirium. So you have here your healthcare worker down the bottom, completely fit and well. This person, if they become, say they have a terrible accident, they end up in intensive care, they've got fractures, they've had surgeries, this person is likely to get a delirium when they have severe triggers. Whereas for someone frailer, like Lily here, it could take very little to tip her over into delirium. So everyone given enough of an insult is likely to get a delirium. These are the things that make you vulnerable. So really anything that increases your vulnerability, reduces the reserve you have cognitively and physically. And the things that can be the trigger factors are all the bad things that happen to people when they're not well. Anything adverse really can trigger delirium. People who already have a cognitive impairment or dementia are the most vulnerable. And these people get what we call DSD, delirium superimposed onto dementia, which can often be very profound and sadly has even poorer outcomes. The point of this slide is not to remember all, it's just to illustrate that we don't really know why delirium happens. Lots and lots of things going on. It's complex, it's poorly understood, and it's multifactorial. It's not one thing, it's a whole lot of different things and different combinations, and will be different for every individual, which is why we need an individualized approach. Right, and delirium is really common as well. These are just some figures. The sicker people get, or the more vulnerable they get, the higher the rates of delirium are. If you look in intensive care, more than 2/3 of people will have a delirium. If you're looking at end of life in hospice, say, it's almost ubiquitous. And that risk goes up every year over 65 as well. So it's really, really common. And we're not very good at picking it up unless we screen. So if we diagnose delirium when we see the person who we think, oh, this person's got a delirium, we'll probably only pick up about 30%, we'll miss 2/3. And that's doctors, that's nurses as well. It's not just one staff group. So that's why it's really, really important that we screen, that we systematically look in the people who are higher risk. Is this person at higher risk of delirium? Is there a tool? And we use the 4ET in Scotland for that, and then go on to assess further. In intensive care, we use the CAM-ICU. So here's the 4ET. Imagine a lot of people will be very familiar with it. To my mind, it kind of takes the DSM criteria and has operationalized it, given it a score that you can add up. And then you can get an indication if it's 4 or above, this person is at high risk of having a delirium. Now, a really important point here, I think, is that the 4ET is a screening tool and not a diagnostic tool. So if you have a 4ET of 4 or above, you then need a proper review by someone who knows about delirium to say, is this delirium? Somebody found at the bottom of the stairs with a 4ET of 12 might not have a hyperactive delirium. They could have an intracerebral hematoma, and I've seen that diagnosis being made wrongly before. So very important that screen positive, you then have the proper assessment to see, is this actually delirium? We also have the SQUID, single question delirium, very sensitive and specific if you have someone who knows and is able to give an answer to the question. So it's good if you have a caregiver, a relative there. Also something we can use for people in a care home or in a hospital where the staff will know what they're like. And I quite like it because you can say SQUID positive or SQUID negative. It sounds quite dynamic. Practice points here. So again, it's important that you have the diagnosis. Communication is really important here. We need to speak to the person, we need to speak to their family if delirium has been diagnosed, what this means. There's a great bit in the sign guidelines about information provision. I think the QR codes are on your desks for that, or will be coming up in the chat as well. So definitely worth having a look at that. And we need to communicate with each other as well, because if we're not telling people that someone's got delirium, how are we then able to manage them well? How are we able to know they're at higher risk of it happening again? So communication is important. So this bit here, I think, is probably one of the most important slides in the talk. We can't get rid of delirium, but we know that if we do the right things, we can reduce the risk of people getting it. And studies have shown there's about a 1/3 reduction in trials if you have a multi-component non-pharmacological intervention. Now that sounds complicated, it's not. It's about doing, I don't like to say basic care, I like to say it's fundamental care. It's about doing the right things for people and doing it systematically, doing it for everybody across the board. And this is an absolutely key area of delirium care, and it needs to have not just one person doing this, you need to have the whole team working together in order to make this work. Say delirium should be everybody's business, and that's really, really important here. So really, we should all be thinking about these things. This is what's in the sign guidelines about what the package should involve. Has to be multidisciplinary. It's all about trying to keep things, I think, as normal as possible. So physiologically, environmentally, as normal as possible for that person. we all need to do a bit. So doctors should be looking at these factors when they're doing their management plans, and nurses in their care planning, HPs when they're doing their reviews and their plans for the patients. I think the managers, and how can we make a system work where these things happen? Most of it's simple and practical things that we can do. It's not anything that we shouldn't be doing. It's part of good care. So, when we see the patient, speaking to them, what's going on, explaining where you are, that they've got the right things. Sleep hygiene, we think that's difficult, but actually I stopped the other day, someone had their once a day antibiotics prescribed at 1:30 in the morning. That's not good for sleep hygiene. Monitors that patients are on, if it's beeping all the time with their oxygen saturations, is anyone actually listening to them? That's going to disturb their sleep. Should we have them on? Can that be safely taken off? Thinking about how we're doing observations overnight, is that strictly necessary? We're talking about pad changing and checking overnight, weren't we, Francis? Mobilisation, getting people up and walking. I think this is about trying to be really proactive about it and breaking down some of the silos we have. We see people sitting around in a chair, not getting out of their bed over a weekend until the physiotherapy can come in. But really, the person can walk. So all of us being able to work on this together. People perhaps waiting for the result of an X-ray that's going to take 3 days over the weekend for the formal report to come back to be cleared. We shouldn't be doing this. We all need to be thinking about how can we ensure this person is given the chance to walk. Pain control is a really, really important one. How often do we see people coming into hospital with something sore, presenting complaint, a sore arm, and they've not been given any analgesia? We know that, I think, people at risk of delirium, older people in general, let alone people with a cognitive impairment, don't do well on PRN analgesia because they don't know to ask, or they don't like to ask. We're thinking about regular analgesia. Are they able to express their pain? Do we need to think about using some of the tools for pain assessment, people who can't verbalise that that's what's wrong with them? I think the wider team, HPs, are really important here. Not uncommon, patients say, no, I don't have any pain, but they don't remember that they have pain when they try and walk, and then they can't walk because they're in pain when they get up. So being aware of that, communication around that. Prevention and treatment of post-operative complications kind of speaks for itself. Hydration and nutrition, again, we can all have a role in this, making sure people have the water, no matter what you're going up to see somebody about, offering them a drink, making sure their mouth's okay, they don't have thrush, that they've not got an uncomfortable mouth, making sure their bowels are working. They always joke that we're all obsessed with bowels, but that's because it really is just so important, and it's everybody's role to be involved in that. Doctors should never be prescribing opiates without thinking about the laxatives. We need to be looking at what's in place for people, what's happening with their bowels. If they're not working, what do we need to do about that? Remembering overflow diarrhea, a big one, which is often missed. We want to be trying to avoid all the catheters, all the lines, anything that's not making things abnormal for that person, as normal as we can. And if we do these things right, we should be able to reduce the risk of delirium by about 1/3. There's no medicine that you can give to prevent delirium. It would be lovely if there could be, but there isn't. However, we should be looking at a medication review. What medicines can we take away? What don't they need for increasing the risk of delirium? And these are just a wee guide, things that we particularly look for, withdrawals as well as use. Opiates is a kind of important one to mention here. We know that opiate analgesia puts you at risk of delirium, but we also know that uncontrolled pain is terrible for delirium. And again, in the business of relieving distress, you don't want the person sitting there delirious and in pain. We often find using judicious small doses of a strong opiate is the best way to get around this, because you can titrate it against their self-conscious level and against their pain level. Minimising polypharmacy, thinking about your anticholinergic burden, all these things. Right. And then this is all the risk reduction. So if you get to the person who actually has a delirium, what do we do? A lot of it's actually very similar, because the same kind of things that we would do to reduce the risk of delirium are what we should be doing in order to treat someone who's already got an established delirium. But there's extra emphasis here, looking at the acute life-threatening problems. Are they septic? Are they having an MI? Are they hypoglycemic? What do we need to do in the emergency cause here to keep them safe? Looking at all the other things that are going on, all the other causes, their medicines, their bowels, their physiology, their homeostasis. Don't just stop at one cause. So people with delirium, it's normally not one thing, it's normally lots and lots and lots of things. So if you find a cause and treat that, you'll be missing the 5 or 6 or 7 other things that are contributing. So we need to be looking at all these causes. We need to be careful as well that if they don't have a cause, don't forget about it. You then go into your prevention. So if they're not dehydrated, make sure they don't develop dehydration, and make sure that you're offering them the drinks. Anticipate the things that are likely to happen and prevent them from happening. Optimization of really everything we can. It's going back to that, keeping things as normal as possible. And that will help us reduce the complications that we've spoken about, all the bad things that can happen in delirium, the falls, the pressure sores. Again, this really needs to be a team effort. It's not enough to have 1 or 2 people doing this. Everyone in the team needs to be involved in this. We used to see people say, oh, they're not for physiotherapy, not for therapy until their delirium settles. That's really old-fashioned. These are part of their assessments, but also part of the therapy for delirium. And if we're seeing anything like that anymore, we need to challenge that. And again, in delirium, we need to be thinking about distress. We need to know that distress is common and is serious. Look for it, anticipate what the causes of it could be, think about unmet needs. And again, Frances is going to talk much more in this later. What I always say, if someone's got severe distress, think basic needs first. So are they in pain? Are they in acute urinary retention? And that's why they're so agitated. You know, are they looking for something to eat or drink? So think from your in a severe distress, your basic needs first, and then you can work backwards from that, exclude them. What else can we move on to? Right. Again, about the communication. So this is back to the sign guidelines bit on communication is absolutely brilliant in this. Make sure everyone knows what's going on, involve the carers and loved ones in the care, working as a team, and then thinking about what you're going to do down the line. We know that people with delirium they might already have a cognitive impairment that's been unmasked, if not previously diagnosed, or they're at increased risk of going on to develop something in the future. So it's bearing that in mind, and if they need anything in the way of follow-up. There's a lot in this, it's a lot to remember, and competent people forget complicated things all the time. So the time's a way of operationalizing this as a checklist that we can look at and make sure we're not forgetting to do all the things that we know we should do, because it's a lot to remember. So this is making a way of us to know that we're doing the right things, your triggers, your investigations, your management, and you're engaging and exploring with the person and their family. Right. When we come to treatment for delirium, there is no evidence that there's any drug treatments that help. However, we are, as I say, in the business of relieving distress. So in very selected cases, if the person is really struggling with their distress, you can't settle it with the non-pharmacological methods. Sometimes we do need to think about using a low dose of a medication, but this really needs to be absolutely the exception rather than the rule. Because if we oversedate people for the delirium, you can end up with your falls, hypoactive, all the things, again, that we don't want to happen. Couple of pictures and slides about why we need the team. You can see poor Lily here is really struggling with delirium, really agitated, hallucinating. This is what we want. We want the time checklist being used. She's okay, still doesn't look too happy, but she's a lot calmer and she's safer. Unfortunately, I think lots of us will have seen this kind of thing happen before when someone falls over the cot rails. So this is what we're looking to avoid, and that's a multidisciplinary effort to avoid that. Again, here she is, poor safety awareness, forgotten she's attached to the drip, forgotten she's unsteady. This is what we want. We want her to be able to walk, supported, get some exercise, get things more normal for her, that idea of being normal. This is what we don't want. And again, sadly, I've definitely seen this, and I suspect others have, someone accident with a drip stand. So everyone needs to be working together on this. Really important that she's at the centre of it. We have the person-centred approach. What and who matters to her being absolutely key, having the people who mean the most to her being invited in to be part of her care. And if we keep the person at the centre of it, we're not going to go wrong. All right. Follow-up, I think we've already touched on this, being aware that the person may have underlying cognitive issues, and paying attention, do they need to have something in place for that, or are we going to review and bear in mind that that might be needed in the future if they don't settle? Couple of delirium myths to bust before we finish. Hopefully I've already explained why delirium is not benign. The next one's a slightly more tricky one because I think we give out mixed messages about this. We spent a lot of time saying delirium is a medical emergency. We need to, this person's at increased risk of dying. We need to be really careful about it. But again, you need to have the person in mind here. So for your young, previously fit person, yes, they probably have something, sepsis, something really bad going on and do need to be in the acute hospital. However, when you're thinking about somebody perhaps more like Lily, who is vulnerable, it might take a more minor illness to tip her over into delirium. So yes, she needs a prompt assessment to work out what the causes are. However, if her causes are things that can be managed without bringing her into hospital, if that environment is safe for her to be there, then it'll be better for her delirium not to come into hospital. Delirium and hospitals are really deliriumogenic environment. They're not normal. The noises are funny. There's lots of things happening, lots of strange people. So if we can safely support somebody without having to have a hospital admission, then that is going to be better for them. But it's all very person-centred. It has to be what's the context at that precise time, and you need the proper assessment to know if it's safe or not. Final myth here is that once you treat the underlying cause, the delirium is resolved. So we used to hear a lot of this. They've had their antibiotics now. Why are they not back to normal? We know it can take time. Sometimes it takes weeks, months, even longer. Sometimes things never quite leave people. And again, often once people get back home, things will start to improve quicker than they would in a different environment. So take-home messages for today. Explain delirium, it's really common and it's really serious. And that's why, why we're all thinking about it, why we're all here today. We can't get rid of delirium, but we can do things to prevent some of it. And given how terrible it is, then that's really, really worthwhile use of our time and our energies. The sign guidelines have been a really great step forward in having this in an accessible way and standardising care. It tells us what to do, how we can do that. Delirium is not caused by one thing, it's caused almost always by lots and lots of different things. So we need to look not at the one item, but look at all the different things that's happening to that person, optimise everything we can, keep things as normal as we can, as I say, for the physiology, for the environment, for the person, and that will help bring them back to the state of functioning and having everyone working on this together, person at the centre of it. It's really what we need to make it work. So thank you very much.
We'll have a chance to pick Hazel's brains and ask questions after we've heard from Frances. So Frances Aiken is a proud mental health nurse, currently working in St John's, which she's been for 3 years, working as a lead dementia nurse in stress and distress in acute adult services. And she's going to take us through her work around stress and distress in St John's. Thank you. You happy with that, Claire? Just that wee one to the right. Yeah.
Okay. Hi, everybody. I'm Frances Aiken, and I'm the lead dementia nurse in St John's Hospital. And I'm just going to hopefully explain easily what my work is and the positive outcomes that we've had in St John's Hospital, so that you can all go away and do it and have the same good outcomes. So I'm not going to read all that to you. There's nothing worse than I'll forget it. So you just read that bit yourselves. And I'll say that, in St John's Hospital, part of NHS Lothian, the second largest board, allegedly, in Scotland. That is obviously our background. There's 30% of patients having a confusion in medical wards, and gives a really high incidence of stress and distress, or distress in an altered reality. Just having even said here that stress and dementia patients are prevalent in approximately 1 in 4 admissions to hospital, and then adding delirium into that mix, it gives us a group of patients that, for want of a better word, can be really quite difficult to manage. So the aims of this initiative was to certainly improve outcomes for patients, affect culture change, reduce the use of restricted practice, and improve experience for both the patients and the staff. And what I've even just heard here today about making sure that our staff is happy at their work as well. The overview of the initiative is obviously knowledge and skills to provide staff with this, what they require to understand how the person with an altered reality can view their world when they have dementia or delirium, the tools that can allow them to continue their assessment process and gather information quickly to discover the unmet need, to reduce the incidence of restrictive practice. I suppose always saying, always adhere to the least restrictive alternative practice by positive risk taking. You know, that was a mouthful for me to say. It's, I hear lots of people saying it, but I don't see lots of evidence that that happens. Improvement for patient, staff's, relatives, carer experience and the outcomes for their care, and the creation of a meaningful activity centre. So the evidence base, everyone using healthcare services in Scotland entitled to the same level of care regardless of their age. I don't know if I see that happening all the time. I'll only talk about my area, but that's up to you to think about that. Every person having the right to have the least restrictive measures applied to their care. Restrictive interventions often at a major contribution to delaying recovery or delaying the discharge even further, certainly maybe by what people think, what the terminology they use when they're writing in the notes. Once we write in the notes, that ain't never coming out. So if you write that someone has, and I always say the favourite term, like the challenging behaviour, that's usually the nicer term, and it's usually violent or aggressive that people have written. And then we wonder why care homes will say, well, they're not coming to my care home. These interventions have been used too much for too long, and we must change this. The drivers were the reduction for the use of restrictive practice, continuous intervention, constant cares, one-to-one, whatever you know them as, number of trained staff, being trained in stress and distress, and an altered reality within St John's Hospital, the reduction of psychiatric emergencies in general wards, and the improvement of patient experience outcomes and their care journey forward. We asked families and carers what they would like to see for the involvement in bringing forward the meaningful activity centre, making sure everything was person-centred. I suppose the development of the dementia nurse specialist within there, and quality improvement. We had the support of the QI team to explore the clinical effect of this service. It's a rights-based approach in its delivery, through the educational component and teaching staff to understand what distress is and how they view it. The understanding of legal entitlements for that person if they have dementia. It focuses on participation and equality with a view that everyone has the right to participate in decisions that affect them. Again, not always something that I see. But aiding a can-do approach to support culture that maximises experience and journey, and enabling and bringing a purpose for every patient every day. I suppose that I feel the heart of the service is aiding just a can-do approach. We can always do it, and that it will maximise the experience to be more positive for the patient, but not just their experience, but for their journey forward. So the evidence that I'm hopeful just to show you in a second, that we've introduced that stress and distress training package being implemented into the hospital. That's not just for, I suppose, registered nurses or clinical support workers, but for everybody in the hospital. Every single one of us that work in a hospital, whatever your post is, you'll come up against someone that has got dementia or distress. So we've included everybody in that. So far, well, it says 750, actually it's nearing 900 now, people within our hospital that's trained. We've had really positive feedback, and that's both personally from relatives and professionally from my colleagues. We have dementia link workers, because now we're wanting to put the theory into practice and not just be that type of thing that people just talk about, but nobody ever does anything about that. And this is some of the feedback that we've had from people. Claire from OT deeply enjoying it, and has impacted on her daily practice. And she's came back to me and told me things that that have worked for her. Our student nurses, I think they're really important. You get your student nurses, you're getting them early. And the clinical decision-making course student, I always get really good feedback from them. A lot of them are usually quite advanced in their practice. So even them saying that there is things that they can find that they can change. And this is just a rundown, really, of who's been trained within our hospital. I include bank staff in it because there's a programme that ran with our nurse director, and getting people that do continuous interventions to get some training, so they don't just sit there bored or they're not interacting, and it's just a pointless exercise for everyone. This is one of the biggest things that I suppose I've been able to achieve whilst carrying out this work. So this is a count of reported continuous interventions versus actual continual intervention. So I don't know about you guys, but I'm not the best about quality, and I never understand it. So I'll explain what I know about this run chart. So the blue line being what's reported by the staff, and that's gathered at the morning huddles, where everybody will have to go from each area and report any safety issues in their wards. Obviously the red being the median and the green being the actuals. So I've been gathering this for 2020. You can see there's lots of peaks. So, but you can see actually as we go into 2023, how what I believe is that we can evidence that our staff are starting to, as I'll just say, they're starting to get it. They're understanding it, because what they are saying, that they've got is much reduced than what it was before. And what I can say is, yesterday, when I left my work yesterday, we had 0 continuous interventions, and previous to that, 1 maybe, and it was a patient that did have a lot of difficulties, but we still managed to fix that for that person. I'm only quoting the nurse director, not nurse director, the site director, who recently told me that he felt that there was a projected save of nearly £1 million a year. I don't know if that's true, it was me that said it, but what I find is that a lot of times continuous interventions, they're just not the best. They just don't work. And us being able to find that unmet need, because that's what this simply is, it's not just huge differences for your patient, for your staff, but for that person. And I can, well, maybe not tell that a lot of people are looking at that and thinking, oh, that'll be great for our hospital. Think of the savings that we could have. But it's thinking about the resources and making this much better for your staff. And something I've always been told, oh, you've got happy staff and happy relatives and happy patients, but you've got happy bosses as well. But when you're at your work, added people that's got stress and distress, it makes your life much harder. And if we're able to eliminate that, it's much easier for the staff to do their job in St John's. This is for regarding falls, before and after intervention. So I'll often deal with people that have fell. And although this chart looks really good, so one person, patient 1, fell 6 times. After the interventions, they only fell once, and sometimes they never fell at all. Unfortunately, these people had to fall to be able to come to us. So what I suppose in a roundabout way, what I'm basically telling you is that the work that was originally, if you like, invented for distress and people with dementia, it works for falls as well. It's not hard work, because I can do it. So if I can do it, MD can do it. It's really easy, and I'm happy to share this with everybody and anybody. Oh, so a patient story. And you can read this, how Mrs. B loved TV, CSI specifically. And when she watched it, it helped her feel calm. She'd done this before her dementia had taken hold, but she knew that she had some difficulties retaining memory. So she kept her Sky remote in her handbag in case she lost it. Because, as I said, she was aware of her difficulties, and she then got into the habit so that she never lost the remote and kept it in her handbag. When she was in the ward, she was viewed as violent and aggressive. This wee lady, no the size of a pit boot, as my boss says, this wee lady that was rampaging round the hospital ward, causing mayhem, pushing the nurses out the way, getting in everybody's road. All this wee lady was doing was looking for a remote. And it only took a few minutes for us to, on speaking to her, to establish that. And as I said, we sourced her a Sky remote that didn't even work. And she was so delighted to have found this, popped it into her bag, and wasn't interested in us after that. But we were able to reduce that continuous intervention because her memory had become, or her cognitive ability had become a bit advanced. She wasn't aware. Her family bought her a box set of CSI. She did sit with the remote and it didn't work, but she believed it worked. And just simply, that was an unmet need met. Really easy. It wasn't hard. It was about taking the time. The Meaningful Activity Centre, through, I suppose, the reduction, introducing the dementia nurse specialist, or the lead dementia nurse, that's me, whatever it is, we were able to make a Meaningful Activity Centre. We copied Wishy General, because they were the ones to start it. I have to ensure everybody knows that. But we do ours very differently. We can use it as a place where activity happens. If somebody's fed up, they need socialisation, they're bored, they can come there, and we have staff that will help with that. But while they're there, we'll be looking, always on the lookout for the unmet need. And that can be simply just through listening to a conversation while somebody's getting their nails done, or they're watching the TV, just quietly listening, and you're able to find out so much when patients are a bit frightened and you just go quiet and let them talk, you can find out so much. And everything that we do is we go around the biopsychosocial model. I always say it's a big fancy Edinburgh word, but when it's just biological, psychological and social in the first wee words there. We don't say no to anything in the Meaningful Activity Centre. This gentleman here wasn't particularly interested in his wife and his kids. He just wanted to see his dog, and it was over the moon at getting to see his dog. This is Mrs. B, this wee really distressed patient who was violent and aggressive. This obviously was after she found her remote. And what the difference that made to that lady was she was bound for a locked psychiatry ward in HBCCC, and we just, these simple interventions, we were then able to send her to a nice care home. For me, that's massive, where her and her family will be able to make memories together, because dementia doesn't mean the end. Some feedback from our Meaningful Activity Centre. My boss, Associate Nurse Director, and she's saying here how Queen Margaret University are starting the process alongside the NHS, really looking into the work so that it can get published. I suppose my favourite one is the one from Angela. Angela's mum was a nurse and had been in the village hospital for a long time and was palliative. And we felt it was really important for our family to come up. We printed out just some pictures of the old village hospital, but then the family was able to share that with the grandchildren, and it was really special. So Angela's wee quote is obviously my favourite one. And this was our consultant geriatrician who, they weren't always on board with us. And I was laughingly saying to Hazel that it's funny me having a doctor to agree with, because I usually argue with them all. But we are slowly changing the culture. And I just want to finish with this wee lady. This lady was a violent and aggressive lady. She never done anything she was told caused havoc. You know the score, you know what I'm saying, what everybody says. And we found her unmet need. Her unmet need for this wee lady was pain. She had osteoarthritis, but just like Hazel was talking about PRN medication, she had PRN, paracetamol, or because she had a dementia, there was also PRN haloperidol. And I'll leave it up to you to think about what PRN she got the most of, but it certainly wasn't analgesia. But look at her. Look at her smiling. And for me, if we don't change the culture in our hospitals, if we don't change the care that we provide, that wee lady will be your loved one, or worse, it'll be you. We can all do it, we just have to help each other. Thank you.
Thank you very much, Frances. And now I'm delighted to add to our panel Erin Walker. Erin is a practice development physiotherapist at Glasgow Royal Infirmary, and she's also the chair of their Active Ward Special Interest Group. And they're now looking to, the reason that Erin's in the secondment to the practice development unit is to spread that work board-wide. So Erin's joining us for our panel session. So if there are questions, Germany will come to online first, and then we can move into the room.
Can you hear me okay? Yep,
Yeah.
just testing. We have a couple of questions in the chat box. Firstly, Carol Hans was well, it's maybe more a comment actually. And I think it was in relation to the earlier part that you were sharing there, Francis. I think Carol was saying that it can work well if the person can verbalise their need. But am I right in thinking that the lady with the remote control wasn't able to verbalise her need? Yeah. Yeah.
Able to verbalise their need. They don't always have to be able to verbalise. It's something that you can just find, and it's not hard to find. The tools that I use are very simple tools that don't give the nurses a lot of work because they just wouldn't do it.
Yeah.
And again, I'm happy to share them with everybody.
Thank you. And the next question then in the chat box is from Jade Gunn. And Jade is asking, is there a guide on what continuous intervention is? She's wondering if that's taught within the stress and distress training. And she just makes a comment that the meaningful activity team have been very helpful to them in Highland.
So there is a guide on continuous interventions. I believe that it originally derived from the Royal Edinburgh Hospital. I mean, for our side of the world, I don't know about Glasgow. And there is a guideline for that, actually explaining what a continuous intervention is and how where it goes down to, or what we call enhanced observations or just general observations. I teach it in my hospital what it is. I'm not sure where it would be available to people in the Highlands.
Okay.
I can find out though.
That would be great. Thank you very much.
Is that you?
Yeah, I'll let you go to the room then. And, yeah.
Any questions from the room for the panel?
It was a question, a reflection and a question for Francis actually, and it was really nice to see your slide with that breakdown of staff, including portering staff. One of the sites I work in is Glasgow Royal Infirmary, and those that are familiar with NHS GGC will know about the link corridor in Glasgow Royal Infirmary, and the amount of patients that I see being taken on trolleys up and down that corridor by porters. And we've talked about transfer, but there are times where transfer has to happen between A&E and the receiving medical ward, and just thinking of that conversation that happens across the patient with porters, you know, in a corridor that is a completely clinical, dreary, grey corridor, which looks, you would think you're going into another universe, you know, from one end to the other. So lovely to see that there's some training going in there. But does that also extend to the domestic services staff that are perhaps going in and cleaning rooms? And
so yes, it does. And the only reason you don't see any domestics on it is because often they're so short-staffed and their managers won't let them come. And that's me just being honest. So within the Meaningful Activity Centre, there's actually a DSR in there. So the domestic staff that work in there have all had the training because I've invited it to them. This is not to be precious. The training is, it's just what I would say the foundations, not how we say the foundations in nursing, it's the foundations being a human being and being kind to another one. Yes, everybody's invited to come.
That's fantastic to see. Thank you.
Can I come in on this as well? Also work in Glasgow Royal, and I think, you know, your point's very well made about the porters, and you see some of them who are amazing at it. You know, they'll have their conversations, they'll be talking to the patient and orientating them and stimulating them. Some people not so much. So I think that the opportunities there are huge things that when we've done our World Delirium Day work, getting the porters, the security guards involved, another group, you know, really need to know about all this kind of stuff. Domestics, you know, as you say, you know, what they're doing, they have these relationships as well. The phlebotomists, we had one of the phlebotomists came up to me and said, that lady was chatting when I took her bloods the other day, but today she's not, and she's really, really sleepy. So I think that's when we talk about it's everyone's business, it is, you know, as you say, really trying to get it from everybody, which makes it's great for the patients, and you're talking about the staff experience. You know, it brings value to people's jobs and makes it better for the staff as well if they're doing these roles, doesn't it? So no, I think absolutely really, really important.
Yep, just to say that there are some comments coming into the chat box for the speakers to say excellent presentations and inspirational. And Annette Charlick, I think I've pronounced that correctly. Annette is asking Francis if you have links. I don't know if it's specifically to Francis, but just generally asking, do you have links to any resources you use? So I think it is for you, Francis, yeah.
A lot of them's just in my head, to be fair, but I do have tools and templates that that I use on a daily basis. Anybody that wants to contact me, I'll absolutely give them, and they're really easy. The training, I have to say, the training is derived from the psychological interventions of stress and distress, and the Newcastle model of care. The unmet need model of care, and the biopsychosocial model of care. So that it all comes from my learning of that stuff.
Great, thank you. And just to say to everybody in the room and also for the virtual audience, we will be sharing the contact details for our speakers at the end of the presentation. That will be on the last slide. And I know that they are more than happy to be contacted to follow up any questions and things. But I do have some more questions. The chat box is really quite active.
Question from the chat box, and we'll come back into the room and then we can go back.
Perfect, yeah. So Karen Mackey has said that they've been supporting the previous stressed and distressed approach, now positive behaviour support, for numerous years in GGC and surrounding areas. Training needs to be outsourced and is not funded. How would we get this training to care homes in line with partnership working?
Is that for me again? Yeah. So the training that I do is that I do it out of my working day and manage it. I know in Lothian and Mid Lothian specifically, not Mid Lothian, East Lothian specifically, they have a somebody that's very similar to me going out to care homes and doing that. And within Edinburgh and Lothian, there's an educational team that specifically goes out to, you know, the HBCCC wards and the care homes. I'm sorry if I don't answer that because I don't know the answer.
No, that's really helpful. Thank you. So back in the room, any other questions in the room? Yes.
So in my experience, the time bundle is a tool that's really poorly completed and poorly adhered to. And I guess my experience of that is it is, in order to complete that well, there needs to be a discussion between the medics, pharmacy and nursing. And I wondered if you agree with that. Do you think that's a bit of a flaw of the bundle itself, that we're not quite there in terms of ensuring that multidisciplinary review?
So when we've been using it, what we've tried to say is that everyone's like, what's my bit? This is my bit and that's your bit. And tried to get away from it being something that this is for you and this is for you. So trying to get the ethos of we should all be looking at all of these things. We should all be aware of all of them. I think sometimes things can feel a bit like a checkbox, you tick off that and you don't actually really think about it. So I think moving forwards, we're almost wondering about whether we take away the tick boxes, because I think there's a thing like, right, done, and that you're not really thinking about it. But it's about the understanding in all the teams about what we should be doing and why we're doing it, and then having that as the aid memoir, because we do forget things. You know, competent people forget complex things all the time because there's a lot of it. So what we've been thinking about is trying to make it more as almost an aid memoir to guide the things that we know that we should be doing, and to try and get away from you do that box and I'll do that box, because I don't think any one bit of it is only one discipline. And we're using you know, we've had the pharmacy have the whole of, I could find it, they've done a kind of a way of having for having time but for pharmacists, but all the different bits of it as well. So I can look it out for you if that would be interesting. But it's trying to have everyone understanding why we're doing all these things. And yes, have I forgotten anything? Did I forget to ask about alcohol? I'll do that. But all disciplines have a role in this. It's not one person's bit to do that. So that's how we've tried to approach it. because it is a challenge. Otherwise, they've been quite reductionist, I think, which is what we want to get away with. It's about the care. It's not about having the box.
Yeah.
It's about doing the right thing for the person.
Because I think at the minute it's viewed as almost a nurse's role to be checking through that checklist, as you say, but actually it is more meaningful just to be having that conversation about all those interventions as a team.
Yeah.
And covering all of those. So yeah, totally.
And I think it's very hard to change this doctors, established doctors' practice. So I know we found that a real challenge, and you're not going to get people, necessarily who've been working for 20 years changing their practice. But education is the why we're doing these things and trying to have it for the new people coming in, similar to what you were saying, Francis, getting people early, having our students, our junior doctors aware of why we're doing this and making it almost part of, this is what we do, this is why we do it, this is your role. I always go on about how the bills aren't just the nurse's role. Doctors need to be involved in this as well, because so much of it is medical. And I think, yes, it can be frustrating that we're not there, but if you look at where we were 10 years ago, there's been a huge change. So I think and despite everything that's happened, I think a lot of it is retained. I was worried a lot of it, the last few years would go, but I think we have retained a lot of it. And so more to do, but I think the progress is there and the change in the culture that we need. Thank you, Hazel.
Yep, it's a question for Erin, and thinking about your role in physiotherapy, Erin, and also I suppose applicable for the wider EHP community. When people are confused and maybe struggling to retain information, how do you best manage that in therapy sessions?
I think it's important that we see, we've already highlighted, we see a huge proportion of these people. I'm based in medicine for the elderly, so if I didn't see confused people, I wouldn't see anybody. It's about taking it back to the basics, making sure that people's basic needs are met before you then try to do the therapeutic things that you might want to do. A lot of it's about compromise, not going in with a fixed idea of what you want to achieve. You might have the patient's ultimate goals and the ultimate things that that they will have to achieve in order to leave hospital safely and be managed in whatever environment they come from. But that might not be achievable in one session or two sessions. It's important about building rapport with patients, finding out really what matters to them, what's the thing that motivates them to want to get out of bed, to want to come and work with a strange person in a uniform that is asking me to get up and walk, involving families, involving carers, asking them to come in and be involved in physio sessions and OT sessions and speech and language sessions. Those sorts of things are really important. And trying to keep the person at the heart of what you do, and knowing that you're not always going to feel like you've won it every day, but not underestimating the value of doing the really small things, like getting people up to sit, getting them out of bed, because all that normalises. You'll all have examples of patients who don't look as if they're well enough to be out of bed, they're really sleepy. You make the effort, you might even have to hoist them out of bed into a chair, but once they're up, they're able to take their diet, they're able to take their fluids, they're able to converse with staff, they're more present for their relatives coming up. So don't underestimate the value of doing the small things. It's not about doing the dead glamorous physio interventions, it's doing the basics sometimes.
Thank you, Erin, and lots of positive comments in the chat box, and I think people will be getting in touch with you.
Thank you very much. Okay, so we're going to move on to our activity part of the session. So I'm going to hand it back over to Hazel and Francis.
Thank you. So this is slightly different thing. I've tried that's over the microphone. Tried it out with various people before, but not in a group like this before. So I hope you find it a useful thing and interesting, something a bit different. what we're hoping to do is give you a bit of insight into what it's like to be the person with delirium, and then how can we translate that into change ideas with the quality theme. What can we do to bring things back and improve things? So we're here today as part of the work on falls. And I think the word has got through that delirium is a really important issue for older people. There's also a lot of work being done in paediatrics and delirium in children. So we know that delirium affects the vulnerable brain. And as people whose brains are still developing, children are actually really at risk of developing a delirium, really high risk, the greatest risk being in young kids and in under twos. And I think the general public tend to know about this. There is unfortunately some children who are really unwell, critically unwell, who do have the kind of very serious, horrible delirium that we've been talking about. But the general public are very well aware of the changes that happen much more commonly to children when they're not well. They know that if young kids get a fever or they're unwell with a viral infection, that they can get sleepy, they can get a bit muddled, sometimes they can hallucinate. This is almost part of what people's knowledge and expectation of the world is. And they call it, in paediatrics, I've seen that they call it benign delirium, or it's called general practice delirium. It's not the bad delirium, it's a different thing. It doesn't seem to have the same bad outcomes. I find this a really useful way to speak to patients and relatives about delirium, because I can say to them, when the kids were young, did they ever get this? And then I can explain similar thing happens when people are critically unwell, or when they're older and they get unwell in the same way. And it's a way of introducing the concepts, I think, without having any stigma involved, and you can then take it from there. So as over the years I've done more work with delirium and speaking to various people, I've realised that quite a lot of us have had experiences perhaps that have been, if not delirium, then delirium-like when they've been young, but we hadn't quite badged them as that in our head, because we're thinking about the thing that happens in the hospitals or to our patients, not about the more things that are happening in our lives. So this picture is me. I'm 9 at my auntie's wedding. You can tell it's the 80s with the frizzy hair. So just after this photo was taken, I went in to get my tonsils out, and it was at the Old Sick Kids in York Hill in Glasgow. And when I went into the anaesthetic room, I was really quite nervous about it. And as they do in children's hospitals, they had trees painted all along the ward, all along the walls to make it look nice, big smiley, happy trees. But then as I was getting the anaesthetic, the trees started reaching out and grabbing at me, and it was absolutely terrifying. That it wouldn't meet the DSM criteria because it was a very short-lived thing, and it was, I think it was probably a bit like delirium, if a very brief episode. And it's absolutely had a lasting impact on me. I still remember it really clearly. Even now, I'm really apprehensive about a general anaesthetic because this made such a terrifying thing to happen to me. So what I'm going to do in a minute is ask you all just to have a think about perhaps your own experiences being younger in childhood, or if there's anything you might in retrospect recognise as being a delirium. Now, there'll be some people, I'm sure, who have had an identified delirium, which could be a distressing memory, so please don't need to go into that. You'll already very much have the patient perspective. So it's not about that. This is about us, thinking back to things that we hadn't previously badged as that. And perhaps you might not want to think about difficult times, or nothing might come to mind. So an alternative is perhaps think about a loved one, either a young child or an older relative who you might have seen have something similar. So you can do that as an alternative, whether it was named as delirium or not at the time. So what I'm going to ask you all to do is take a wee minute, close your eyes if you like, and just cast your mind back. Is there something that you or a loved one have experienced that could be delirium or delirium-like? Can you remember what happened and how it felt? And what I'm going to do is give you a minute just to think about this, and then some discussion either in your tables in the room or in the online chat groups, which you should be magically going into just now as we speak. Okay. So that's been about a minute. If people want to have a bit of a discussion in their groups, having a think about, have you had a delirium or delirium-like experience? What happened? How did it feel? Pick up conversations, but again, we're going to struggle to get everything done if I don't. So one more discussion, and this time, oh, this isn't working. Can we try? So thinking about all the discussions you had, is there a way that you can use that to change things when you go back to your place of work? Because certainly thinking of my experience, it's now common practice to have parents in the anaesthetic rooms with kids. So we can change things and make things better. So are there things from what you've discussed today that you're then going to be able to think about when you get back to your normal workplace? What we're going to do is another few minutes on this and then some feedback. So if you could maybe have a think about someone in your group, and especially for the online groups, who might be able to feedback about this. That's great. Thank you. Everybody, I'm going to have to stop you there for just now. Again, so sorry to break up the conversations, but we'd really like to have some, to hear about all these wonderful conversations that you have been having. So I think if there's anyone in the virtual groups, if they would either want to speak or put it in the text box, in the chat box, if you could do that just now and let us know, and we will come to you. Brilliant, brilliant. So we might then start with one of the groups in the room. Would anyone like to tell us about what they've been discussing? I think that's really important, isn't it? Is getting things, ingrained as this is what we do right from the very beginning. I agree, that's really important. And I think that's, as nursing, medicine, HPs, no matter what your role is. And were you thinking about specifically what kind of education were you talking about there?
So I think we were thinking of even that think delirium and what it actually means, but also talking about 4AT and SQUID, because we were just a conversation was that isn't always filled in well, or people don't know, or it's not until something happens we look at these things. So how do we do these things before we have a fall or before there's a harm in the system?
Yeah, so the real understanding of delirium care and why we're doing it.
Thank you. I think part of the conversation we had as well was we have got some people not with personal lived experience themselves, but through their relatives. And actually that importance, whether it's deteriorating patient, whether it's delirium, of acknowledging that they're the person who knows, in PEDS as well, they're the people who know that person, and not just to dismiss there's something not right here, or they're behaving in an unusual way, they're not themselves, or whatever that might mean. And whether that is, to say, delirium, or whether it is deterioration, then we don't respond in the way we should, and we don't acknowledge the importance of that, I think.
And I think it's so true, isn't it? Is that, that's not my mum, is, I think, Ken Rockwood is one of the big professors in geriatric medicine out in Canada, and his delirium work is all called That's Not My Mum, because it's that understanding that we have. I've recently had one of my children have some health problems and some hospital stays, and even in paediatrics, it's still a thing. People don't listen in the way that you would. Most people do, but there are people who don't. So it is just so important that we value that. Agreed. Is there anything coming in the online, or should we go to another?
No, feel free to go to another table. There's nothing coming just yet.
Well, only one more minute, sorry. too much conversation. Is there another of the tables who would like to let us know what they were talking about? Any other ideas? Because I could hear there was lots of chat. Anything else to feedback on? I guess I won't put you on the spot, but lots to think about from it, isn't it? And I think, yeah, we've spoken about the education about delirium and about the theory behind it, and it's also about the why we do things. And Francis and I were just chatting, weren't we, about sometimes you know all the theory and you go in with your healthcare hat on, but people can forget the human aspect. You almost have it trained out of you sometimes. So it's trying to keep that focus on that human aspect and the relationships with people, acknowledgement of them as a person, and keeping that throughout as well. Okay, so thank you all so much.
So thank you so much to our speakers, Hazel Miller and Francis Aiken, and for our panel member, Walker. I think we've heard a lot today about why delirium is important to think about in our care. So delirium is common, it has serious consequences. We've heard about the ability to reduce risk through having a reliable approach to screening and delivery of high quality fundamental care, and that we need to do it together. It's a team sport. We need to do it together for all of us as older adults in training, but importantly as us as human beings. You have your evaluation forms on your table in front of you. If you wouldn't mind taking a wee minute to fill them in, that would be brilliant. There is also delirium toolkits on the table, which you feel free to take away. Those are under review, so there are a few links and things in them which are no longer active, but the content has been screened and is still clinically relevant. So feel free to take them. And there's also Q information on the tables for you to take away as well. So thank you so much today for our in-person participants, our online participants, and thank you again to our speakers and to our organising team, Jamie, Joan Marie and Drew. So thank you again.